Start.
Hello, Assalamu alaikum, all my dear colleagues, and I'm honored to be here to be discussing this very popular topic, which is called the stem cell therapies, and I'm very thankful to the organizers. For those who don't know me, I'm Dr. Ruqqia. I'm a consultant neurologist, and I'm currently working at Sheikh Khalifa Medical City. So I have no disclosures, so I will proceed straight to the objectives. My objectives for this talk are that firstly, we like to make sure we understand what stem cell therapy actually is, that it is a potential therapeutic treatment, and it's becoming more popular for MS. It is also to understand what are the potential benefits, the risks and pathological uncertainties which are still regarded with this treatment. We'll like to discuss the criteria for those patients who are eligible in MS treatment regimen, and to update regarding different clinical trials in MS. And lastly, I would like to discuss a bit more about pregnancy and stem cell transplant, and a little bit about stem cell business. So stem cell therapy is also called the regenerative medicine, has been promoted and has had tremendous interest from many all around the world. We know that ablation of immune system followed by autologous stem cell therapy for treatment of MS has been explored for approximately 2 decades. And studies have demonstrated that it is a high efficacy treatment for suppression of inflammatory activity, and there is evidence that it leads to also neurological improvement. And this it does by promoting the repair response of disease, dysfunctional or injured tissues using stem cells or their derivatives. There are different types of cell-based therapeutic strategies with different purposes and different safety profiles. However, there is a misconception that cell-based therapies can be used as routine treatment in all patients with MS. We know that there are several approved MS treatments in the past 2 decades, but they're not fully effective, and overall treatment effect is uncertain. We also know from the different trials that stem cell therapy is quite effective, although there are some concerns about its safety. Let's talk about first what is a stem cell. Stem cell is the body's primitive raw cells. It can self-copy and divide, and it replenishes its population, thus generates other cells with specialized functions such as nerve cells. Pluripotent cells develop into more mature cells. They can create, maintain, or repair the body tissues. There are many different types of stem cells, and we have all heard about them. They include embryonic stem cells, adult stem cells, which are of various types and include blood stem cells, mesenchymal cells, neural, epithelial, and skin stem cells. In addition, there are induced pluripotent stem cells. For this talk, I will be basically talking about the adult stem cells. So stem cell strategies to treat MS is based on 2 types. One is the remyelination, and the other one is anti-inflammatory therapy. The remyelination occurs due to direct oligodendrocyte progenitor cell replacement. Also because of utilization of mesenchymal cells to deliver trophic factors to endogenous oligodendrocyte progenitor cells. There are also pharmacological manipulation of endogenous oligodendrocyte progenitor cells. The anti-inflammatory therapy occurs by immunoablation followed by autologous hematopoietic stem cell transplantation, which we will discuss in a little more detail. So this process of immunoablative or myeloablative therapy followed by autologous hematopoietic stem cell transplantation is also called the rebooting of the immune system. It consists of several phases. The first phase is called the mobilization phase of the autologous peripheral blood stem cells, followed by collection or harvesting or cryopreservation of these cells, followed by ablation or conditioning using different regimens to eliminate existing immune cells. And this phase is called the treatment phase. Followed by this is the transplantation phase, where the reinfusion of the peripheral blood stem graft happens, and along with antithymocyte for in vivo T cell depletion. During the aplastic phase, different levels of supportive care is given to the patients for several months, which include antimicrobial and antiviral prophylactic treatment. Recovery phase, most patients do not require any additional therapy after this procedure. So the immune reconstitution following this stem cell therapy is ablative conditioning that leads to depletion of abnormal immune cells. And following 6 months of this treatment, the hematostatic expansion of T cells occurs with potentiation of immune regulation. And 1 to 2 years following post-transplantation, immune renewal happens through thymopoiesis, which generates naive CD4 and CD8 cells and new and diverse immune response and thymic function. Parallel to all this, naive B cell reconstitution restores B cell and antibody diversity happens. Now, it is very interesting to note that thymus is exquisitively sensitive to several insults during this stem cell therapy, including the conditioning drugs, corticosteroids, infections, and graft versus host disease. Impaired thymic recovery has been associated with increased risk of opportunistic infections and poor clinical outcomes in stem cell recipients. And this is achieving a lot of interest currently. So what type of optimal conditioning is best? This question is uncertain. They believe that high intensity regimens have highest toxicity, so it's no longer used. And low intensity regimens is believed to be well tolerated, but is believed to be less efficacious. However, the most popular is the intermediate intensity regimen, also called the BEAM, and it's being used in a recent trial which is ongoing called the BEAT-MS, as it's believed that it's a reasonable compromise between safety and efficacy. However, in the MIST trial, a low intensity regimen was used, and studies showed quite good efficacy with the stem cell treatment. So what are the studies in the stem cell treatment? Coming to our next objective. There are several studies, and majority of them, although they are multi-centers, have been retrospective observational studies. So they were there's more a comparative and observational study. In further studies have been done, which have been single-arm phase 2 trials, and majority of them, as you can see here, are either 1-center or 3-center trials, and we will briefly discuss the HALT-MS treatment at the trial, which occurred in 3 centers. There were 25 cases. Few cases showed further studies, which in our phase 2 trials, you can see they have been done in either 1-center or multi-center studies. One popular study is called the HALT-MS study, done by Nash et al. In 2017. These were 24 patients, primarily relapsing remitting MS patients who had failed to respond to other conventional therapies. And over 91% of these patients showed no progression of disease activity, and almost 86% showed no clinical progression, relapse, or MRI activity. And you can see from this slide, as I have discussed before, that in HALT-MS there were only 3 deaths reported, but these deaths were not related to transplant. therapy. And the Canadian phase 2 trial by Atkins also showed similar results. However, we only two randomized control trials. One is called the ASTIM, and the other one is the MIST. The ASTIM.
Go.
In the ASTIM phase 2 trial, it was a comparative multi-center trial between treatment effect of mitoxantrone and stem cell therapy in aggressive, relapsing, remitting, and secondary progressive MS. And overall, it showed that there were T2 lesion over 4 years were 79% lower amongst those receiving stem cell therapy compared to those who were on mitoxantrone. In the MIST trial, which was done in 4 centers, was also randomized and rater blinded. Population was 18 to 55. Patients were relapsing, remitting, MS patient with greater than 2 relapses, whilst they were taking DMT in the prior year, and the EDSS was between 2 to 6. It was a non-myeloablative immunoablation regimen that they had, and this study also showed that stem cell as compared with DMT resulted in prolonged time to progression or time to first relapse. However, the high efficacy drugs like alemtuzumab, Ocrevus, and cladribine was not included in this. Moraro et al. In a Nature review in 2017 has beautifully shown that proportion of patients with NIDA at 2 years was far higher for patients on stem cell therapy than others, including high efficacy drugs. And also the need for DMT after stem cell therapy was below 35%. So having said how good and efficacious stem cell therapy is, we're all aware that it does have safety concerns. There are early toxicity, which are not uncommon, and MS relapses can occur during the mobilization and conditioning period. There are complications of leukapheresis and adverse effects of the cytotoxic agents, which can be used, especially in high conditioning regimens, including cancer drug type side effects, also infection and hemorrhage, and even engraftment syndrome, which consists of fever, rash, and pulmonary, liver, or renal impairment. The late toxicities are rare. It includes infertility, viral infections, secondary autoimmune disorders, and myelodysplastic syndromes. However, the current estimates of treatment-related mortality is 0.2 to 0.3%. So the safety side also, we have studies to show that it can be offered to patients with highly aggressive MS. But what are the type of patients that this treatment would be most appropriate for? And most of the studies that are currently using the same type of eligibility criteria, using relapsing remitting multiple sclerosis patient or progressive MS patients who have had progression for a very short period of time. The recent clinical inflammatory activity, example relapses in the previous 12 months, and the recent MRI inflammatory activity. They should be young, mainly they're saying age should be less than 45 ideally, and should have short disease duration of no longer than 10 years. Low to moderate disability on EDSS score, less than 6, or if they are 6 or 6.5, the highest score must have been reached within the previous few months, and the patient has clinical MRI inflammatory activity. They should have failure of approved high efficacy disease modifying treatment, and they should not have any substantial comorbidities, and should have the capacity to give informed consent and to adhere to treatment and recommendations of prophylaxis in the immune compromised phases. So the caveats of published data on stem cell therapy is relatively, it's because it's relatively a modest amount of published data we have currently, and the studies are done in different population group with different therapeutic protocols and outcome measures. And the two randomized control trials had suboptimal control groups. Stem cell therapy is a reasonable option for highly active relapsing MS with inadequate response to other available high efficacy therapies. And currently 5 multi-center randomized control trials are occurring comparing stem cell therapy versus high efficacy therapies, and they are in progress. And they include the RAM-MS study, the BEAT-MS study, which are phase 3, and also the STAR-MS. The NET-MS and COAST are currently in phase 2, and they are comparing the high efficacy drugs to the stem cell therapy. One observational study was done in 2020 by Christina Zoksvitsky, who showed that the treatment with stem cell was associated with higher likelihood of maintaining no evidence of disease activity as compared to alemtuzumab. However, adverse events were more frequent with stem cell in the first 100 days, but thereafter more common in patients with alemtuzumab. The BEST study is currently being performed, and it is a randomized controlled trial, rater blinded, and the criteria is similar to what we've discussed, but they're comparing the stem cell therapy to high efficacy drugs, including the newer ones like ofatumumab. The primary endpoint would be the MS relapse-free survival, and secondary endpoints would be annualized relapses and event-free survival, and several others. And you can see that this is happening in 19 study sites in the US and UK. And the criteria for this trial is not very different from the ones that we discussed, but at least one episode of a relapse must have occurred on an oral agent or monoclonal antibody, and one episode must have occurred within 12 months prior to screening visit. And one episode must be a clinical MS relapse. So after discussing about the autologous stem cell therapy, I would like to talk about the mesenchymal stem cells. This helps promote repair by intrinsic tissue stem cells and stromal cells that can be isolated from bone marrow and many other adult tissues and culture expanded to purity in high numbers. Mesenchymal stem cells have repair properties, but cannot generate nerve cells or oligodendrocyte themselves. Established methods are being confirmed to purify for purity and functional capacity. However, these can be ideally administered in several ways, including locally, intrathecally, or intravenously. Variety of immunomodulatory, neuroprotective, and repair-promoting properties through cell-cell interactions and elaboration of soluble factors have been noted. Experience in a variety of human conditions supports safety and benefit. And there's a few studies that have been done recently, and they have shown that the benefits on disability is far more than lesion activity. And the cells should be harvested directly from culture and not cryopreserved. And intrathecal administration, they believe, probably works better than IV administration. And they also showed that multiple administrations are needed. Now, one of the case report was recently, unfortunately, showed that one of the patients who had intrathecal injection of mesenchymal stem cell developed a tumor in that site. So there are some caveats that we need to be aware of, as it is an evolving treatment. And this study, which showed beneficial effects of autologous mesenchymal stem cell in active progressive multiple sclerosis as well, but through intrathecal administration rather than intravenously. Now, coming to the stem cell business, we all know that it is the buzz of the probably the new era, and my patients are often asking me about this, and even throughout the world, they're saying that ideal seeds for treating diseases. So it's not just for the multiple sclerosis, but it's being used as a treatment for several autoimmune diseases, including systemic lupus and Crohn's disease. However, there are also people who are arguing that we should hold our brakes on stem cells unless we have more evidence and we know exactly what we are doing before it's been marketed so openly throughout the world. And why is this? Because there is lack of regulatory oversight and compliance with approved regulations. There is lack of transparency regarding the type and integrity of the cell product that is being used, the procedures performed, and the potential risks. There is lack of follow-up or communication with the treating neurologist. There is misinterpretation of an unproven therapy as practice of medicine or patient-funded research. There's also lack of accuracy of marketing claims about safety and efficacy. So with this, I would like to just quickly proceed to pregnancy and stem cell. So a retrospective review from European Bone Marrow Society and the registry showed that out of 324 women aged between 18 and 50 who were undergoing stem cell therapy for autoimmune diseases from 1994 to 2011, 22 pregnancies occurred in 15 women. And these patients were not just only with patients with multiple sclerosis, but also with arthritis and Takayasu's disease. Out of these 22 pregnancies, 20 pregnancies followed natural conception, 15 resulted in healthy live births, but 7 failed. However, no congenital or developmental abnormalities were seen, and there is substantial risk of infertility. Pregnancy sometimes is possible. Case series in MS of stem cell with beam yielded similar results, which was presented by Sophie et al. MS in her journal, in MS Journal in April 2021. And she showed that patients' rate of pregnancy-associated complication post-stem cell treatment with beam conditioning for MS. She looked at the registry from 2010 since 2010 in tertiary referral centers, and 55 patients with 30 being female of childbearing age at time of transplantation were noted. Pregnancies occurred, 2 pregnancies were carried to term, and no maternal or neonatal complications were reported. 2 pregnancies were not carried to term due to elective terminations, and of the 21 male patients, 1 patient had fathered 3 children since his stem cell therapy. There were no newborn complications. European Society of Blood and Marrow Transplantation annual meeting in 2019. Nina Saluja from London also looked at data from 5 studies on almost 550 pregnancies in stem cell survival, and she showed that the rate of live birth was higher and the rate of miscarriage lower than controls. But obviously this depends on availability of fertility preservation techniques, type of procedure, and especially the chemotherapy and radiotherapy used, because this can carry a high risk of infertility. Fertility preservation is performed in all patients undergoing stem cell in most European countries, but some do not cover the cost. So in summary, in our personalized medical era, we have an unmet therapeutic need, which remains despite increasing numbers of DMT for MS. Stem cell therapy is a potent therapy, and data from recently published patient series indicate that stem cell may have significant higher treatment effect than currently registered immune modulating treatment for MS. And the new studies hopefully will show more clarity. With improving safety issues and better patient selection, this would probably show better results. The financial costs are there, but these are mainly front-loaded, and stem cell is an option for patients with highly active relapsing MS who have failed the available high-efficacy medications. It should be performed at a designated center with experience both in transplant and MS management. Ongoing trials will determine where stem cells should be placed in MS treatment algorithm, and I look forward to that. There should be better understanding of thymic function as it would improve the stem cell outcomes. Recovery of ovarian function and viable pregnancy is a realistic but relatively still rare possibility in post stem cell patients, and we need to look at that and probably in more detail in the future for our patients. So with this, I end my talk, and I will be very happy to take any questions. Thank you for listening.